Good morning, everybody. I've been asked to basically talk about lung cancer and EBUS-TBNA, and that is exactly what I'm going to be discussing very shortly. Thank you, Dr. Malay Sharma, for asking me to speak. So before we go ahead, everyone should go through this paper in the Lancet Respiratory Medicine in 2015, which in the UK was done as an open label pragmatic randomized controlled trial showing the use of lung cancer diagnosis and staging with endobronchial ultrasound not too long ago in 2015. Because diagnosis and staging of lung cancer is an important process for the treatment options and prognosis. The disease status of the mediastinal lymph node basically is imperative, where the intent is curative, and it also helps in transbronchial lesion sampling, where CT-guided or any other needle, transthoracic needle approach may be associated with higher risk of pneumothorax. So the importance of lymph node involvement is that lymph node metastases remains one of the most adverse factors for prognosis in non-small cell lung cancer. The presence of mediastinal lymph node involvement indicates at least stage 3A or 3B. So we know that in stage 3A, the patient can still be operable with adjuvant therapy, but 3B is inoperability, treatment by chemotherapy and or radiotherapy. Also, survival months after treatment, depending on the stage, are different. It helps you in prognosticating your patient. Now, 50% of lung cancers that present are having distal metastases at presentation. And in these patients, we sample the most distal metastases. But when there is intrathoracic disease alone, the algorithm for diagnosing metastases becomes a little bit difficult. So what we do is try to get primary disease options, which can be bronchoscopy, CT-guided biopsy, or endobronchial ultrasound-guided transbronchial needle aspiration or core biopsy. And even in PET-positive nodes, in curative cases, we need tissue sampling to either upregulate or downstage the disease. As you can see, this is simple CT-guided biopsy. If there's endobronchial disease, bronchoscopy, but here it could be bronchoscopy plus minus endobronchial ultrasound. And the questions that the pathologists ask the clinician is it malignant or not? Is it primary or metastases? And if it is lung cancer, whether it is small cell or non-small cell, because treatment options vary in both. As far as non-small cell lung cancers are considered, with squamous cell, no further molecular testing may be required unless the oncologist asks for it. But in non-small cell squamous cell carcinomas, you will need mutation testing of KGFR and KRAS and FISH and ALK gene assessment as well, for which you need tissue. So let's come to a patient that presents to you at the age of 67 with dry cough and weight loss for about 3 months, ex-smoker and incidentally abnormal X-ray. You can see there's a lesion here. Now, if you were to go do CT-guided biopsy, then it would mean there's a more than 20% risk of pneumothorax. Bronchoscopy is the first choice. So therefore, in this patient, we did a bronchoscopy. As you can see, there is no endobronchial disease, but there appears to be an extrinsic compression. Now, in this case, endobronchial ultrasound is an extremely good guide to help definitive diagnosis. And as you can see, endobronchially, you can see a well-localized lesion here, which clearly, by doing transbronchial needle aspiration cytology, gave us the diagnosis of squamous cell carcinoma in this patient. Now, does additional sampling, even if there was endobronchial tissue, endobronchial mass, does additional sampling techniques increase yield? And in this paper in 2012, they showed that the diagnostic efficacy of combining bronchoscopic tissue biopsy and endobronchial ultrasound-guided transbronchial needle aspiration increases the risk, increases not only the diagnosis, but also subtyping by immunohistochemistry and EGFR testing in adenocarcinomas is useful. So even when there is endobronchial lesion, if it is necrotic, sometimes using a node EBUS-guided non-necrotic area TBNA sampling can help increase the yield of the tissue. And the combined procedures yield, as you can see, in a patient who had endobronchial disease alone. So we've always had this mindset that it should only be done in transbronchial lesions, but in certain endobronchial lesions as well, Bronchial biopsy plus EBUS-TBNA, and this paper showed increased diagnostic yield from 75% to 93%. So therefore, in not just staging, we are just talking about a transbronchial lesion here or an endobronchial with a transbronchial extension. It helps increase yield. And coming to mediastinal lymph node sampling, when we talk about staging, you all have been listening so far from all the speakers that mediastinal lymph nodes, all of them are accessible except subaortic, which is station 5 and 6, and paraesophageal station 8 and 9, where combined EBUS and EUS techniques help you get maximal sampling. So coming to this patient who had a central mediastinal tumor, 59-year-old, presenting with stridor, ex-smoker of about 50 years, and showing this CT picture. What options do you have? The options that you have is either CT-guided biopsy with the risk of pneumothorax, bronchoscopy, and EBUS-TBNA. So in this patient, endobronchially, there was no extension and needed endobronchial ultrasound guided transbronchial needle aspiration. Now, what would you do? EBUS-TBNA, core biopsy, TBNA alone, and with cell block. So lots of studies have shown that a core biopsy and EBUS-TBNA on the slides with a cell block are both good enough. So if you do not have a core biopsy needle, doing a transbronchial needle aspiration, also taking samples enough for cell block, which means at least 3 passes to increase sampling, will help you get the same diagnosis as a biopsy tissue specimen will do in trained hands. Does needle size matter? The studies have shown that there is no difference in yield with a 21 gauge versus a larger needle. So therefore, 21 or 22 gauge is good enough as long as the sampling site and the node selected are correct. So when we say node selected should be correct, what do we mean by that? So previous reports have shown that lymph nodes which have the following sonographic characteristics on B mode and vascular pattern were deemed as probably malignant. So if you see a node which in short axis is 1 centimeter or more, is round in shape, has distinct margin, has heterogeneous echogenicity with a loss of central character, and abundant blood flow with varying vessels, diameters, and tortuosity. If there are more than 3 or 4 present, choose the one that is the largest, choose the one that looks rounded, choose the one that has more vascularity in it, and your definitely your chances of yield will be increased. Now, when we do staging transbronchial needle aspiration, you do sequential visualization. So start with 2R, 4R, 4L, station 7, 10R, and then 10L and 11R, 11L. But having said that, while staging, you sample the furthest size site first. So you sample the N3 node first, then the N2 node, and then the N1 node, and in that order. So because that will give you a diagnosis. If you were to sample the node which is closest to the lesion that it is, your needle will may get affected. So it should be N3, N2, and N1, and label each slide as you go along. It has to be very methodical, and your assistant must know and sample and call out N3 done, N2 done, N1 done. Okay. For example, in this patient here, he had a right lower lobe mass and then also had a station 7 and also looked like an 11L node. So what would I do? So the mass is on the right side. So what would be the furthest node? It would be the 11L node. So I would go first to 11L, take the sample there. Then I would come to station 7, and then I would sample 10R. So that would be N3 node, N2 node, and N1 node. So that is what you need to remember when you're staging the EBUS. For example, in this lady, a 64-year-old who presented with hemoptysis and had this lesion, which looked probably like a blood clot, but it turned out to be a mass in the left upper lobe. But she also had on staging CT a node on the right side, 10R, and a station 7 node as well. So staging CT chest was suggestive of T3N3 disease. PET also showed an active 10R node and a left upper lobe mass. In bronchoscopy, we did not find any endobronchial disease, but EBUS showed that in the anterior segment, there was a left upper lobe transbronchial mass. So what we did was we first sampled the transbronchial mass and put the needle aside. And at that same sitting, we did a staging EBUS in spite of PET being there, because PET positive nodes are not necessarily malignant nodes. PET only shows increased uptake, which can also happen in inflammation, which happened in this lady's case. Although PET showed active 10R node, when we sampled, the 10R node was negative. So this lady was downstaged and received radical radiotherapy. So that is how staging CT is important. So another word of caution again, use separate needles for transbronchial mass and separate one for staging mediastinal lymphadenopathy. And as discussed in this paper, it has been shown that EBUS-TBNA compared to PET-CT, tissue confirmation is always recommended if the patient is in a curative intent of lung cancer. Coming to radial EBUS, in peripheral lesions, radial EBUS not only helps guide where the lesion is, also helps in sampling, but it is not real-time sampling that you do. However, it reduces the risks of pneumothorax, etc. And as you can see, a lesion here is well-rounded on radial EBUS, which you can sample under C-arm guidance. And that can give you a diagnosis. Now, coming to factors that improve yield. So most important is knowledge of your endobronchial anatomy. Please attend to the lectures carefully. It is going to be repeated over and over again. But if you know your endobronchial anatomy, you know where you're going. The technique has to be perfected. And obviously, EBUS guidance helps. You should know how to take the guidance. And when you've taken the sample, rapid on-site cytology is very, very helpful, because in a study, it showed it can increase the yield from 83% to 91% if done straight away. Also, if your friendly cytologist tells you that I've got sample, you might not need too many extra passes to be done. And the material can be directly appropriated, which basically means if you've got enough material on the slide, put it all on the cell block, because it helps them not only in immunohistochemistry, but also in molecular testing. For the more the material they have on cell block, the easier it becomes for them. And the aspiration technique has to be correct. Should it be auto or should it be manual? There is no consensus on it. Depending upon the node, it might be helpful. How many aspirates to be taken? There's no clear guideline, but it is advised to take 3 to 5 aspirations. Studies have showed that you reach a plateau after 7 attempts. So 3 to 5 in a node is more than enough. Usually 3 passes must be made in a node to say whether it is a dry node or whether you've received maximal sampling. What about needle size? As I have said, the inner diameter of both is the same, and yield is in most studies the same irrespective of size. Now, while preparing the specimen, you should prepare specimens of slides in dry and in formalin. If you have a core, you take it for histology, because that improves nearly 14 to 35% yield in different studies. Many people are now using not TBNA, but TBNA core biopsy needles as well, and those are very helpful in receiving cores. If you do not have a core biopsy needle, then preparing it in cell block can increase the yield significantly again and allows for genetic studies as discussed before. The general recommendations for genetic testing are that cell blocks are highly recommended for optimal testing and can be performed on the primary tumor or a site from the metastases. The blocks are quite important, and a minimum of 300 to 500 viable tumor cells are required. Therefore, not slides, but blocks are useful for these EGFR and KRAS testing. Last but not the least, training is extremely important, and it is recommended that trainees should perform at least 40 procedures in a supervised setting, and 25 procedures should be done annually to maintain competency. The learning curve is very steep, but practice makes perfect. So keep doing that. So if I were to summarize my talk, TBNA is an extremely important mode of diagnosis and staging of lung cancer. Conventional TBNA must be mastered by all interventional pulmonologists. Technique, adequate aspiration, and appropriate specimen preparation remain cornerstones of good yield, and there is no alternative to supervised training and experience in improving yield. So therefore, I hope this has been useful. Please go ahead and start practicing, and that will help you. So thank you very much for your patient hearing.